Welcome, everyone. This is your host, Vince Jackson, back for an exciting series this time. And we're going to be talking about, a workforce strategy journey a little bit, as especially in the realms of the healthcare industry. And we have two amazing guests here. But just to kind of give you a little bit more about it, today's going to be the introduction into workforce strategy journey. And we're going to take a holistic view of the workforce management and why strategy and a holistic approach truly matters. We're talking about what that journey is with workforce management, why it's not just about staffing. There's so much more to it than that, and we'll get into those details. This duo, or we could probably talk for days. We're going to talk about the key components of workforce management and the financial and operational impact to poor workforce management. And of course, we're going to talk about the role of technology and data and automation and all that good stuff in today's industry and how it is key to helping you stay on top of things and being successful. And we're going to, really dive in a little bit to the leadership aspect of it and what their role is into making sure that your strategy is successful. Leaders, listen clearly, because you guys are really important in making sure that we set the stage and follow through on the things that you're trying to achieve and making sure they go through to success. So I'm going to pause a moment and introduce the two people we have with us. Sarah, let's start with you.
Dr. Sarah Inman here. As Vince mentioned, the guest on this podcast, also his trusty sidekick, but we'll leave that for another day. But I am so excited to really be doing this series with Mickey. I'll let him introduce himself, but Mickey's been a friend of mine for years, and I think immediately bonded just over our passions and also frustrations with workforce management strategy and this connotation of it equals staffing, and that's all that there is, particularly when you're talking about healthcare in general. So we came up with the idea of really breaking this down into a series where we could talk about all of those different key critical elements that we've seen and experienced over our careers, and then also open it up and have it be a larger conversation, because we don't feel enough people are talking about this. There's nowhere else to go that we can dive into these sort of things, or geek out with others who really are super interested and passionate about how to do this right. So super glad to be here today. And Mickey, I will let you go ahead and introduce yourself.
Hey everyone, thanks for the invite, guys. Super excited to get to join you over on this podcast. You guys have built a phenomenal following, have a great reputation. So I'm a little bit humbled, to be honest, to be joining. So my name is Mickey D'Angelo. I'm Chief Outcomes Officer at Ango Systems. Prior to this, those of you that are clinicians sitting in the hospital, sitting in staffing office, doing system administration, that was me for 20 years. I grew up, lived, breathed this stuff. And Sarah, I think you're exactly right. I think through our careers, we've seen what we've been doing hasn't moved the healthcare organizations and the industry as a whole really where it needs to be. There's a lot of emphasis being put on when we talk workforce management. A lot of times we're talking about resource planning, perhaps, and how many FTEs do we need? What's the recruitment cycle? Or we're talking about staffing and are we actually allocating that? But we don't often take the step back and actually look at the forest, that all of this stuff is intermixed together. And what I'm finding both in my own organizations and as I work with organizations is we're missing it because we are so tactical on a day in, day out basis that we don't take the time to strategically look at how all these things work together. And let's be honest, in today's world, we think of everything going on at the national level within U.S. healthcare and the impact that it's having on reimbursements. We already couldn't afford staff shortages. We already couldn't afford to be inefficient. That's only going to get worse. And so I think you're exactly right. Like, we're having a conversation, but it can't just be us having this conversation. It really has to be all of us in this industry pulling our thoughts, learning best practice from each other, learning who tried something and it worked and who tried something and it didn't, and finding our path forward, because what we've done in the past is not going to get us to where we need to go. So super excited to kind of dig into this.
Everything you said, right, are things and conversations that you and I have had in the past. We've talked to customers about it, and you really nailed it when you said we're looking at it and we're talking about it in a lot of instances on a national level. The nursing crisis in the United States, that gets the headlines, that gets the attention, but we're not going all the way back to the beginning of how and why these things have happened and things that people can and should be doing to mitigate it. We can't solve the global nurse staffing crisis, but it goes beyond that. And I think people lose that. For exactly like you said, they can't see the forest through the trees because they're firefighting mode. It's, oh, I'm short a nurse today, so I've got to handle it today. They're not going back 2 years prior to the processes and policies that weren't put in place to avoid being short that nurse in the first place.
So I was listening to a webinar maybe 2 weeks ago, and there was a CEO of a major hospital system, and he made this statement, and it boggled my mind. It's changed the way I thought of this. We've been talking about nursing shortages for 20 years. Like, it's always been a topic. And yes, it's ebbed and flow of how bad it is. Like, it got really bad, obviously, during COVID. We recovered a little bit. Stats show that we're going to go back down again. But in 20 years, can we continue to say there's a staffing shortage? Or should we just admit that this is the market and we need to learn how to adapt to it?
So can I ask a little question to poke in on that a little bit, right? You know, look, I came from retail. We always said there was a shortage as well. Everybody says that. Let me ask this question. Is it a shortage problem or is it a retention problem?
I would answer it's both. It is a shortage problem, it is a retention problem, but it is also a lot of other problems that tie into that. It is a care delivery model problem. It is a financial reimbursement problem. It is a orientation and skills building problem. So it is all of those things, and also just one of those things depending on the lens at which you're looking at it, which inadvertently, Vince, you literally have led to the reason Mickey and I wanted to do this in the first place, right? Because it's so easy to just say, oh, we can't retain our nurses. The hospital down the block is paying $10 more per hour. Okay, well, let's dig into that a little bit. And that's really, I think, the crux of this whole series and all of those different areas that we really want to dive in and focus on. So even if one takeaway is helpful to somebody who's listening, or it helps start a conversation within their organization, hopefully it can start a little bit of a ripple effect and an impact. Also, Mickey and I are single-handedly going to fix the nursing shortage. That's what we're telling you on this podcast, everyone. So tune in. We've got all the answers right here.
If I looked good in tights, I'd say I'm coming to be a superhero, but I do not.
Prove
to
it.
The point, though, you're exactly right. It plays into all that. But as much as we're saying workforce management isn't just staffing, it is also scheduling and staffing. Because I think one of the problems we have is even when we have the staff, we don't effectively use them. How many organizations, if we pull up their data today in healthcare, that are spending incentives because they need more bodies on Tuesdays? Every Tuesday, I need more bodies. But if I look at the same data, every Thursday, they're sending people home low census. You have the people, in some cases, not all, in some cases, you have the people, you're just not effectively scheduling them to actually meet the flow of demand that could be forecasted.
I want to throw out an example here, and we've immediately devolved into this, which honestly was to be expected when you get Mickey and Vince and I in a room together talking about anything related to workforce management. But at a hospital I worked at previously, I worked with one of my leadership to develop, we called it the resource nurse program. So essentially what that was is we took nurses who, for whatever reason, were not able to work a full shift on a given day. It may be childcare constraints. Maybe they were back in school. Maybe it's just flat out, I'm tired, I can't do a full 12. We would bring them in for a 4-hour period around shift change. So peak admission discharge time from the ED, folks coming in and out. However, we implemented the program. We had people who were readily signing up, gave very clear guidance of, listen, give them your discharge, have them go pass meds, have them start IVs. Here's the ways that you can use your resource nurse. And it did not succeed because the leaders within the department said, well, if you're going to give me a nurse, I need a nurse for the whole 12. You don't, though. Yeah, you may still need a nurse for the whole 12, but we've given you an extra set of hands to handle the tasks that are necessary and critical in lieu of a full 12-hour nurse. And you're automatically pushing it to the side and saying it's not going to be effective, because you only can understand the delivery model through the concept of a 7A to 7P 12-hour event. And I see that now in my current role at Improv. I go in and I consult with these organizations, and time after time, when I talk to them about the way they're using their nurses, they look at me like I have two heads, because it's, well, you bring a nurse in for 12 hours, here's their assignment, and if census drops, you send them home. That is what we have to talk about. Those are the mindsets that we need to shift and change, because it won't necessarily be a panacea for everyone. But if we're not willing to look at it differently, we're always going to continue to get the same result.
It was funny. So I was recently admitted in the hospital. I'm fine now, no worries. Like I'm good. But I had 2 stays, and one of them was an observation unit. And of course, I took advantage of my time there, talking with the nurses, and they learned what just because they're people, we get to know each other. They learn what I do, and all of a sudden, I have my room filled with the charge nurses and the nurse manager, and we started talking about, well, of course, in an observation unit, tons of churn. We talked about the same role of how much they would have loved to have something like that, because they see so much patient churn, and their general staffing model didn't take that into account, so they didn't always get that full 12-hour nurse. But they're like, because we do so many admits and discharges in an observation unit, we would love that extra resource nurse just to be doing that, because that's what's raising the workload. We know that in nursing, the heaviest workload is trying to do the admits and what discharge. So if you can take care of your core patients with your 12-hour shifts, but then that increased workload with resource, why would you not? And there's been, we're talking about one creative, and I don't even know how creative we can call that one model.
Right.
I've heard of so many others. Technical care assistants, where they brought people from Best Buy in to just help with all the technology stuff on a floor, so the nurse didn't have to screw with it.
Yeah.
Like, there's all these other care models that exist that can alleviate the burden of our nurses.
I think that's a great point, Mickey. And I think, when we look at it, not to carry over lessons from retail, but, I think they were on the forefront of breaking shifts down into smaller patterns and being more centric around the customer demand and the actual employees' needs, to really breaking shifts out. I mean, like you guys keep talking about that 12-hour shift. Why does it have to be 12 hours? I mean, has somebody got a magic button out there that says that's the optimal shift? You could probably be more efficient. I get that you can't just drop a patient and another person pick them up, right? There has to be a transition and all that good stuff. But that overlap may actually be more efficient than hammering people with 12-hour shifts. So I think we really got to look at this more holistically and think about what can help people, help the customer, and create, the supply needed to help the demand and improve the retention and be a good financial model and like you said, Sarah. Yeah,
to bring
Mickey,
us back to strategic, we need to look at this strategically. I think I have yet to talk to a nursing leader that hasn't admitted that perhaps 12 hours isn't the way we need to be anymore. But we also have, some embedded nurses that's the way we're going to operate. But we also know we have a new generation of nursing coming in that want unbridled flexibility, that would probably love the idea of more flexible work schedules and stuff like that. The question is, who's trying this stuff out? Who's finding what works? Who doesn't? And when they find it, it's the, when one organization does do it real well, as much as, like, as an industry guy, I'm like, man, share the magic sauce, man. Because we all need to learn. Like, we have a whole population of health that needs to be cared for, but they're thinking, oh man, I have the magic sauce, and I'm competing for the same talent. I'm not giving that information up.
So here's one of the interesting things, though. You don't have to. I mean, if you're in the healthcare industry and listening to this right now, and you're courageous enough to want to go try and do something a little bit different, you know who we are. Reach out to us. Now, secondly, I want to say that you don't have to actually implement it to model it out to some degree. Again, sorry, stealing lessons from my background, but we use data. We use a lot of algorithms. We use a lot of different inputs in the retail sector to do a lot of mapping. You can do that in healthcare too. You can put all the pieces together, all the right relevant data. You can start mapping it out to see what can and can't work. And at least you narrow it down to that point to what is the art of possible and start trying those things out. So it's not like you just have to go into this blindly. I mean, there's a lot of things you can do with a good data analysis and looking at what you need to do. So hey, I do want to pull us back a little bit too. We're hitting all over this and we kind of kill beyond staffing a little bit, but how do planning, recruiting, scheduling, timekeeping, and connecting all these pieces together with one strategy, what does that mean, right? Holistically. And I think we hit on that a little bit, but let's back up just a little bit to say, what is the overriding strategy that we're trying to get to? What are you trying to communicate out there to the audience?
I think from my point, when I think of this, like, again, we usually talk staffing, but there's all this upstream stuff. If we start further upstream and we look at how you're doing resource planning, like, for example, a lot of the math behind resource planning in healthcare isn't as mature as we'd like it to be. They're glorified spreadsheets, but they don't take into account some of the intricacies that are needed to actually determine. For example, if we give a unit an FTE count, we say, hey, based on your average daily census, here's the FTE count you need. What that usually incorporates is the math that behind it is a 1.0 FTE. Well, a 1.0 FTE is not what's, to the point of the conversation we've been having, isn't what's working. It's usually a 0.9, a 36-hour shift nurse. To cover the same number of shifts with all 0.9s versus a 0.1, you actually need greater FTE, more than that FTE count. So we could be, before we even get to staffing and scheduling, if you're not calculating and taking in things like seasonality, that FTE count, things of that nature, you may be behind the 8 ball before you even get to scheduling and staffing. And then we take into account, you have position vacancy. I have one hospital system in my hometown that their med surge is running 35% med surge vacancy. So if you miscalculated the first one, you have a 35% vacancy. Then we talk about PTO, 22%. Usually that gets added on to your FTE, but in this case, they were only adding in 10% of, hey, people take 10% of PTO. Well, what about that other 12%? Because they average 22% utilization. So I'm not going to go into all those details, but the idea that there's this like domino effect from the very beginning until we even get to schedule creation, that all these things have to strategically work together. And to your point, Vince, we have to understand the data and the metrics behind it so we can strategically come up with solutions for that before we even create a schedule. So for me, and then that's without talking about retention, upskilling, like all these other things that also involve workforce management. That's where my head goes. Sir, where's your skill?
Honestly, what I was thinking as you were talking is, on the one hand, I'm so thrilled that what I'm seeing more and more of today in the industry are positions and departments being created that specifically are workforce planning, workforce strategy. Because when I first started working in a hospital, there was no such thing. You maybe had a centralized staffing department, but even then, showing my age here, that far back, a little few and far between. You had HR that was handling their recruitment. The CNO had their position management, but it was completely separate from, what other departments were doing. Nobody was talking. So we're seeing a little bit of a shift to where people are starting to understand that the whole workforce has to be viewed as one microcosm and not all of the different individual departments and leaders who are doing their own thing with their own budgets. And the CFO and the CEO are concerned about hitting the budget numbers for the organization, not realizing that they have segmented all of these different groups in a way that make it impossible to actually meet any of their goals. So having said that, I don't think we're anywhere near there yet. I have hope that we're getting at least more people aware of it, because there is an understanding now that we need these, types of organizations or types of roles. But even then, primarily what I see is they're focused on nursing. They're not focused on the entire house. And listen, nursing is critical, right? But again, when we talk about how do we leverage people to the top of their license, how do we utilize non-licensed labor in a way that also can impact patient care and positive outcomes, those are the things that aren't being viewed. And until we take that full step back, we're going to continue to have this challenge and these problems. People are retiring. The boomers are aging to the point that we're going to lose all of this really significant knowledge in the workforce without the number of people needed to replace them. Plus, not to mention, all those people as they age are now going to be patients who are admitted in the hospital. So census is going up, acuity is going up, all of the other associated things. So if we're not looking at how I leverage my staff in the physician offices in order to hit the needs within the larger healthcare system, if I'm not looking at, you talked about Best Buy bringing in techs, right? If I'm not looking at my IT team in-house to figure out how we fix the wows up on the units, how are we ever going to get to a point where we really can solve what is essentially a body problem when you talk about staffing? Is there's not enough bodies, and there's not going to be without somebody who's looking at it from all of those different perspectives.
I absolutely adore that you brought in outside nursing, because I think you're right. That's been the focus for years. And I know I've been one of the ones banging the drum that we need to think full house. What impact does EVS have on infection rates, for example? Just one small item, but we could go through the gamut. To me, I think one of the magic bullets is actually forecasting, like forecasting our volumes and actually making intelligent evidence-based decisions based on those forecasts. What part of the healthcare doesn't have volumes that can be forecasted? There's not one. There's not one that can't do that. And Vince, you mentioned retail's been doing this for ages, or call centers, or move your way through the list. And
Even
healthcare,
manufacturing, yeah, you name it.
We're
Yeah.
special. No, we're not.
Everything I'm hearing you two say, it kind of goes back to, are you building the right staffing model at the center of it, right? I mean, at the center of it, do you have the right staffing model? Because that, in theory, works back upstream to say, am I recruiting the right people? Am I filling the right roles? Do I have a financial model that we can support, that supports what we need? Do I have a model that supports our client and needs from patient's perspective? I mean, really, that's at the center of it, and is kind of an output versus necessarily a strategy in a lot of healthcare places at this point. I'm going to kind of move us on to the next section here a little bit, which is,
it's like herding cats.
Hey, no, it's perfect. It plays into it well. Now that if you plan that poorly, what's the impact?
I would say what it does to the organization is exactly what is happening every single day, which is we are in reactive firefighter mode. We're constantly stressed. There's never enough staff. Administrators, nursing leaders, charge nurses are spending all of their time focused on what's happening today and maybe the shift following. And it never allows us to truly operate from a perspective of being able to fully focus on patient care and patient outcomes, because all we're thinking about is how we staff that next shift. And it's why, Mickey, as you said at the start, right, this conversation constantly comes back to staffing and the expectation or the thought that that's what we mean when we say, a holistic workforce management strategy. But that everything you described, Vince, I love how you refer to it as an output, because that's exactly right. It's not a strategy. It's here's basically a deliverable of all of these different things that I've put into play that I think I'm doing the right thing because I don't know any better. But when we take it back even a step further, if we're not looking at and identifying areas that we can do things a little bit differently, if we die on the hill of we've always done it this way, we've got to do the 7 to 7 12-hour shifts, if it's we have to recruit in this manner, all of these things are going to just continue to get us exactly what we have now. And any one of those items you mentioned being tweaked or zoomed out to look at from the very beginning, I think can have an impact. It may not completely shift, but it's enough for organizations, I think, to say, okay, we might be onto something here. So now we're willing to look at another small microcosm of that output a little bit differently. But otherwise, it doesn't matter how you package it up or what order you put those things in, you still are going to wind up with the same outcome at the end of the day. And I think that's really the crux of why Mickey and I were like, for goodness sakes, I think we got to take this to the people and we've got to start talking about it, because maybe someone will hear it and realize and say, okay, yeah, I do have to go back to the beginning of what I'm putting together to get that output in order to make a change.
But when workforce management isn't done well, again, soup to nuts, begin to end in a strategic manner, there's three primary negative impacts. And when you do it well, obviously it's a positive impact. And the first is why we're in the business at all, patient care. It hurts patient care when we don't have the right people in the right place at the right time. We cannot give the patient care that is needed to help people be their best selves. And when I say people, I don't just mean patients either, because the second part of that is employee well-being. If I'm short staffed, that's where I lead to burnout. If part of workforce management is making sure people are paid right, if we don't do that, studies show pay someone incorrectly twice, you have a 50% chance of losing them. Like, play that through the rest of this journey. Like, so your whole employee engagement thing, or I prefer the term wellness, is shot. So your patient care is hurt, your employee wellness is hurt, but so is your bottom line, because now you're spending money where you don't need to spend money, which is then having adverse impacts on the entire thing. And so I think you're dead on. Our clinical leaders, they're not holding on to it because they have any bad intent.
Mm-hmm.
They've been in survival mode for decades, really, and they're afraid to give up control to even a new workforce management team, or when you set up a central staffing office, because, man, I've barely kept this together myself over the last 10 years, and this organization has done enough bad things to me that I've had to consume that were bad ideas that they abandoned a year later. I'm not giving up my staff, because my staffing control and my workforce control, because I know what some of those other things have done. So I've seen a lot of organizations, one of the first things they need to do is rebuild trust with their frontline leaders to even move in this direction, and bring their frontline leaders along for the ride to show we're actually all trying to get the same thing. The McKinsey study recently had shown that clinical leaders, one of the things they hate, they're trying to fill shifts. Like, that's their ton of time a day trying to do that, but they hate doing it.
Mm-hmm.
They want to go back to investing in their clinicians. Like, wait a minute, most of us on the workforce management side, we have the same goal as you. Can we partner together to actually find ways to do this?
Yep, you nailed it, man. I think, well, a couple things. You may have heard me chuckle a little bit when we talked about, bad experience, right? If you don't have the right staffing and everything else. I laugh because I was actually at an office this morning with my wife for an outpatient thing. They ran an hour and a half behind, and they started running behind at 8:30 in the morning. I was like, good Lord, what's going on that you're that far behind? And you're not only impacting other patients and my wife and me, because I'm sitting there not being able to go do what I need to be doing and having to scramble to change meetings. I mean, you're absolutely right. One little thing off and you're impacting a lot of people. And what does that make me go? I'm like, do we want to use this doctor going forward? I'm questioning it, right? But the other thing too, to kind of circle back to, is there's that resistance that you're talking about, right? I don't know if it's resistance versus been burned, right?
Mm-hmm.
There is a resistance there, but there's usually a genuine reason for why it is. Sometimes it's just because it's always been the way it is. How do you break that barrier down? How do you get people to do exactly what you're talking about? I can share that, and this might not, I think this is very different, but in retail, right, when we were working in massive stores and organizations that had like departments with, 50, 60 people, we would try to build a model at the top level, figure out who can work cross departmental, but we always gave that end ownership to the department leader. So that we did a lot of the math, a lot of the calculations, a lot of the work, and put it down in front of them, but left that ownership with them to do the final tweaking. I don't know if that works in healthcare or not, right? But there's also resistance further upstream. So I don't want to leave it just with the department people. There's a lot of resistance throughout organizations. How do we get past that? How do we challenge that?
I'm saying this from the perspective of somebody who's lived it and has been in that situation. And Mickey, you really nailed it when you talked about like not wanting to give up. Like, I've been the one to keep this going for the last 10 years. Like, I can't hand it off to somebody else. You have to build the trust. And it seems, that's a platitude more than anything, right? Like, of course, that would be nice, but you have to show a willingness and a commitment, I think, from the most senior levels of the organization, that this truly is the direction they want to move in. They are showing the intent and desire and expectation that they are going to move in a different direction, that this will be successful come hell or high water, whatever language is necessary there, what that takes. Because at the end of the day, what a nurse manager is not going to do is relinquish control when she fears that her staff, or more importantly, her patients, are at risk. And that's what this comes down to. And senior leaders need to understand that whether it's the time commitment, the visibility commitment, the financial commitment to show that they are all in on this and they're committed to making this work, and that safety is paramount to them. I think that's where most of these initiatives fail, frankly, because I don't blame a nurse leader for holding on for dear life to her schedule if she's, as you mentioned, been burned before and she had to come in and work a 24-hour shift because they didn't have any staff, because somebody messed something up, or she had a sentinel event occur, or she had a patient get hurt, or she had a staff member get hurt because somebody else dropped the ball. And for me, I think that's probably the biggest barrier, is these folks who have lived in this mode for so long, who, you go into healthcare because your desire to take care of people is so strong that you can't even consider an easier career path, right? So to ask people to just blindly trust that it's been broken for decades, but now all of a sudden it's going to be different, is almost impossible if you're not willing to put your money, your time, your effort, all of those things where your mouth is, and prove to the leaders who have been carrying this burden for so long that it's for real this time. Because how many of all of us dealt with false stops and starts in a hospital that, oh yeah, this is it, this is going to be the thing, and it's not even remotely close.
Yeah, I think I'm going to piggyback on that. I'm going to say the word governance structure. It's the idea that you have emotionally intelligent leaders that are partnered with the frontline leaders to accomplish the same goal. But those leaders also have to have the organizational fortitude to push through the inevitable change management curve that comes with it. It's a cultural change. Cultural change is harder than any other change in the world. And it takes organizational fortitude to do that, and emotional intelligence. But I'll piggyback and say a second item. Nursing, particularly, and healthcare as a whole, is an evidence-based practice. And the clinician friends listening, you can send me nasty emails about what I'm about to say. But in my experience, nursing is an evidence-based practice until we talk staffing and pay. Then all of a sudden it's an emotional based practice. And Sarah used the word fear a moment ago, which is an emotion. Now that those emotions are valid, I'm not discounting the validity of them, but I'm saying we need to bring the evidence. Vinci, this is what you were saying, I think earlier. We need to bring that evidence back and actually have evidence-based practices to why we make the staffing scheduling decisions that we make. And yeah, bounce them against clinical knowledge and those type of things, but it has to come back to, we're using evidence to drive the information and drive the actions we're taking.
And I think, and not to go down a rabbit hole on this, but I think it's really important. There are a lot of folks, and zero shade to any of them. They're all very highly trained. I've been in programs with many of them, but we have a lot of people in administrative roles today who do not have a clinical background. And when you talk about evidence-based practices, and it's such a buzzword in healthcare that almost people tune it out. But when you are talking about a industry full of clinicians who have been trained from their very first day in nursing school or medical school to focus on the data, to look at what the numbers are showing, to use the scientific method to draw a through line, if you're not approaching it from that evidence-based perspective, you're going to be dead in the water, because you're already introducing doubt to people whose minds are very highly trained and attuned to focusing on the best practices that have been proven, that have been validated. However, flip side to that being, how do you get evidence-based best practices if everyone's too scared to try, right? So we are in a chicken and an egg situation where we're kind of at an impasse, and figuring out how we bridge that gap, I think, really is part of this overall final frontier we're in terms of breaking through to the next level and the full holistic workforce management strategy is we have a lot of different competing mindsets and backgrounds and philosophies and things that all play into this that are really difficult to break when it's been Florence Nightingale beat into all of us all those years ago that like, no, you got to focus on what works, like pay attention to the outcomes. Then how do we go on innovation and trying something new and being willing to shake things up a little bit in the pursuit of something better?
Lots of good information. We've talked about, we've covered the full gamut here. I think we just solved all the world's problems when it comes to healthcare if they would just listen to us, right? We talked about data a little bit. What are some of the other areas around technology, data, and automation that could potentially help with this problem? We talked about forecasting and stuff like that, but I know there's a lot of other pieces of the puzzle too. But what are some of the highlights you guys see out there that should, as they're thinking about the strategy, thinking about how do they revamp their thought leadership on scheduling, planning, forecasting? What are some of the other elements that are out there today that weren't there even 5 years ago that they should be making sure they put into this strategy?
I struggle with this question, to be honest, Vince, and let me tell you why. In my 20 plus years in healthcare, we keep introducing new technology and saying, oh, this is going to solve it. This is going to solve it. And doesn't. Why doesn't it? Because everyone keeps doing the same practice. They new technology, but I'm going to keep doing it the way I've always done. You know, and so, well, we could certainly talk, like obviously AI is the hot buzzword. I'll be honest, within workforce management, I'd say 90% of organizations, if I was to introduce AI into helping them make proper staffing, scheduling decisions, they couldn't utilize it.
Mm-mm.
Why not? They haven't adopted the technology they have today because most everything's still sitting on a piece of paper on the nurse's station. So I introduce AI, they're going to say it's giving me bad decisions. Well, why is it giving you bad recommendations or so on? Because it doesn't have the right information. The information's sitting on a piece of paper somewhere. We don't adopt the technology we have today, we're never going to be able to take advantage of the newer things that are coming down the line.
It's again, going back to the zooming out, it's the chief informatics officer having the foresight to update processes and policies that have language that are supportive of AI so that when the new workforce management planning VP comes into the organization and says, I want to leverage this solution that uses AI in the background to see which nurses are most suited to fill these open shifts, we don't have a blocker where the CIO is going, oh, we absolutely won't do anything with any type of AI technology, right? So we're staying out of our own way when there are opportunities to do things differently, which, not to beat a dead horse here, but it's the whole reason we're having the conversation. Because that's not happening, we're tripping over ourselves at every turn, that even when something new or innovative comes on the market or is an idea that somebody hears on a podcast or reads in a case study or sees at a conference, the infrastructure is not there within the organization to actually act on it. And I think really that's what it, not to drill this down into a 5-second soundbite, but what this comes down to is a failure of infrastructure at the end of the day. There are a whole lot of people doing the best that they know how to do, but looking at their small slice of the pie in their silo, and it's keeping us from opening up to all the possibilities of how rapidly things are changing in technology with AI, just in the market in general, and being able to make an impact. And as a result, nurses are getting burnt out, they're getting stressed, they're getting hit by patients, they're leaving the bedside en masse, and we're creating a bigger problem as a result because we did not go back to the basics and get our house in order.
The only thing I'm going to add to that is some of the reason too that we see that where technology is almost a burden today is because organizations have allowed and out of all the reasons, good reasons, like everyone's just trying to do what they need to do, but there's a lack of standardization within the organization of how they do things. Well, how can you develop a technology to meet 15 or 16 different ways of doing the same thing? when really there are some best practices we should be adopting. Then we can actually optimize our technology, and it gives us the agility to, as new things are introduced, we can execute change management, we can change practices, because everyone's kind of out playing from the same playbook. That's not happening in most organizations today, though most organizations I talk to have a desire to go there. Is usually, again, the lack of organizational fortitude to really push through the political and culture change needed to move that direction.
Yeah, takes a lot of discipline. So you guys played into my hand quite well, because on our last topic here, it all boils down to leadership, right? And leadership taking the forefront of where do they need to go, setting that strategy, all that good stuff. So let me ask this question. What must a leadership do differently to ensure success, both in workforce management, but in general, right? Because you guys just hit on some topics that go outside of that have a direct influence on workforce management. So it's a little broader than just workforce management. What are if you can name 3 things that they have to do, what are they?
Call me and Mickey, listen to our podcast, and forget everything they think they know about workforce management. I say that tongue in cheek, but also not really. We have to rethink everything we think we know about the strategy around workforce management in general. Because I think, as we've proven today, the majority of folks come from a perspective of everything they think they know is that staffing box. And if we don't get them out of that, if we don't open their eyes to the need to be able to bend a little bit, to shift, to broaden those horizons and ways of thinking, to make that umbrella bigger and pull in all of the other necessary people, that's hard, because we're asking leaders to, again, relinquish control to not even the clinical leaders, like we're talking C-suite executives. And I think it's a matter of shifting mindsets to a growth mindset of, there's more to this than I thought before. There's got to be a better way. So let me lean in and listen and talk to the people who are in all of these other areas that could have an impact. I think that's the start. If there was a magic pill, I'd be coming to you from Bora Bora right now, because I would have figured out how to get it on the market.
Your organization likely doesn't have the answers because you've been tactically focused on a lot of things. And so looking for the right partners that can have a little bit more broad view is a big deal. Beyond that, I would say, grab a sledgehammer, and you got to take a sledgehammer to every one of those silos that exist in your organization. HR doesn't have all the answers. IT doesn't have all the answers. Operations and clinical operations don't have all the answers. Finance don't have all the answers. But all 5, like all of those, need to be collaboratively working together in workforce management. And so if you have silos within that, you got to bust them. As long as silos exist, you're not going to move forward. I would also say, if you don't have a defined owner of your workforce management program, like if I went to an organization, I do go to organizations, like I could sometimes just be talking the application, not even the full program. Who owns it? Oh, payroll owns it. IT owns it. Like, they own this part. They own this part. They own this part. And my answer is, well, nobody owns it then. If everybody owns it, nobody owns it. You got to select who owns this thing.
So I want to be clear there too, by owning, meaning that you have a point person. They're not a dictator. They're
No.
responsible for working with all those other groups that you just talked about, to
Bingo.
making sure that they deliver on the success that they're all trying to get to. And to add a little bit too, right? I mean, if you bring in a partner like us or a consultancy or something to help you, we're not going to have all the answers either. But what we're going to do is help you find the right answers, get to a resolution, get to a strategy, get to a plan. I always alluded it back to, we're outside the hedges that you can't see over. We know what's going on in the industry. We know what's going on in technology. We know what's going on in the workforce management realm. Whereas if you're inside the hedges in your organization, a lot of times you can't see what's going on out there or have the exposure. Leverage people who can help you get there. It always pays dividends in the end. It always does, whether it's us or some other organization that has the expertise to help drive it. it's key that you make sure you're looking at this holistically, as you both put it, and come at it with an approach that's going to be successful.
I would say look outside of healthcare and how workforce is done. Look into retail. Look into call centers. Call centers are probably the most mature when it comes to workforce management principles, and their ability to execute it and use the technology. Learn from those. Not everything's going to carry over, but let's not throw the baby out with the bathwater.
Well, hey, we are coming up here close to the end here. So what I would love to do is just kind of give you both, a minute to kind of do a recap based on everything we hit today, to kind of say, why is having a great strategy around workforce management important? What would you say?
I think from my perspective, the reason it's not just important, but it's critical is the safety and well-being of your patients and your staff depend on it. And in healthcare, even though, as Mickey said, all industries think they're the special snowflake, but in healthcare, we have that added component of our product, what we're selling, our consumer base is a patient. There are human lives on the other side of it. And it has to be looked at through that lens from the perspective of it being a deadly serious conversation and problem to solve, because for a lot of people it is. And the data's out there. Patients die every day because of bad staffing decisions. I got a pin at a conference a decade and a half ago that said safe staffing saves lives, and it still is true in my head every day when I have a conversation with an organization that's trying to figure out what this needs to look like. And because it's not just staffing, you owe it to the people who are entrusting you with their care, with their loved ones' care, to figure out how to get it right.
The only thing I'd add to that is, we talk to organizations, and what you'll hear when you talk about building a workforce management is, I can't afford that. And sometimes that's, I can't afford the time, I can't afford the money. They're pulled in 1,000 directions. I'm with you. This is too critical. You can't afford not to. Rural hospitals, we know, are about to get pinched pretty heavily, and they're thinking we have to cut money. Well, if you don't take a strategic approach and invest in actually taking a strategic approach, it's going to cost you more. And so you just can't afford not to give this due attention that it needs. It can no longer sit on the back burner as a nice to have. It's a must have. We must look at our workforce management strategies and assess them from beginning to end.
So can I recap that by saying, if you're not planning to succeed, then you're planning to fail?
I'll buy into that.
So I think that's a key element, right? And it kind of goes along with that, slow down to speed up as well. Invest now to be more excellent on the backside and execute better and deliver better. It's a tough thing to do, though, to stop yourself. Sometimes we have to just stop and make sure we're going down the right path, right? Everyone should be doing that on a regular basis. Pause. Am I doing the right things at the right time with the right people? All of that, right? Check your rights and see if you got any wrongs before you continue to move forward. So, hey, this is a great podcast. I love it. I think, everybody will find this exciting. Just a reminder, this is just the first one in a 5-part series. So Mickey and Sarah will dive into this more on the next 4 episodes. We hope you tune back. If you have questions based off of what we talked about here, reach out to us directly, whatever the case may be. It goes along with topics you also wanted to hear us talk about beyond even these 5 episodes. So look forward to the feedback on this. Sarah, Mickey, thank you so much. I think this is a great one, and we'll wrap it up and put it in the books. Until next time.